So the next topic or the next area will be cystectomy, removal of the bladder. For patients who are diagnosed with high-grade or muscle-invasive bladder cancer, there's the option of undergoing what is called a radical cystectomy. In males, it's called a radical cystoprostatectomy, and then in females, it's also called a radical cystectomy or a pelvic exoneration. The difference is because in males, we remove the bladder and the prostate, seminal vesicles, vas deferens, and the surrounding structures, as well as the pelvic lymph nodes and extensive lymph node dissection to remove all the lymph nodes around the pelvis, all the lymph nodes where the bladder cancer and the bladder cancer may drain into. In females, the removal of the bladder, as well as sometimes the anterior 1/3 of the vagina. If the female still has her female organs, such as the uterus and the cervix and ovaries, those will come out also. Thus, that's called a pelvic anterior exoneration. Once the bladder is removed, then we would then have to figure out a way for the urine to be collected and drained. And that's called a urinary diversion. There are three types of urinary diversion. In general, there's something called a catheterizable pouch, where using intestines, we form a pouch which then be connected to the umbilicus or the belly button. And then through that, through catheterizing several times a day to empty the pouch. Then there's something called a ileoconduit. Ileoconduits when you take a smaller, shorter portion of the intestines, in this case the ileum, connect the two kidneys and the ureter to one side. The other side you bring out until a little nipple, usually somewhere on the right side of the abdomen, lateral to or away from the belly button. And that will require an external bag to collect the urine. All right, that's called ileoconduit. The third option is of urinary diversion is considered a neobladder, where you take a longer piece of intestine, sometimes both the small intestine and part of the colon, and form into a neobladder or a fake bladder. And that bladder will then be reattached to the urethra, and that bladder will then be trained or trained into becoming to stretch out to be a bigger reservoir or a new bladder, of which then urine will be collected, and then manually you either do a Crede method, where you physically push to empty the bladder, or a combination of pushing and squeezing or putting pressure, what we call a Valsalva maneuver, to empty the bladder. So I will talk more about the specifics of each of those. But the first thing I want to talk about is the cystectomy. Cystectomy is performed robotically, typically through small incisions around the belly button. And once the robot will be used to assist in removing the bladder, the surrounding tissue, the dissection of the lymph nodes, as well as the other organs. If in female, the prostate, seminal vesicles, and vas deferens. In the male, the prostate, the seminal vesicles, and the vas deferens. In the female, anterior portion of the vagina, as well as the uterus and the ovaries, if needed. Meaning, if a patient already has a hysterectomy or oophorectomy or salpingo oophorectomy with a hysterectomy, those organs, of course, don't need to be removed because they have been already removed. That procedure, that portion of the procedure usually takes about a couple hours in removing the bladder, the surrounding tissue, organs, as well as the lymph nodes. The second part of the procedure is to do the urinary diversion. If the urinary diversion is an ileoconduit, of course, that is a quicker and more simple procedure, so it would take less time. And on average, that would take maybe an hour, hour and a half. However, to form a pouch or a neobladder, that may take another 2 to 3 hours. So in all, a radical cystectomy with a urinary diversion could be anywhere from 3 hours to 6 hours, depending on the type of urinary diversion and the type of surgery, meaning if there are more organs to be removed, of course, it will take longer. Blood loss for me, in my experience for this surgery, is typically less than 200 to 300 cc's. Again, the vast majority of my patients do not need to have transfusions. The surgery is a big surgery, so prior to surgery, if you are having a neobladder, I would recommend some type of training or some type of counseling and understanding or how much work it would take and patience it would take to train the neobladder, live with the neobladder, and be able be accustomed to having a neobladder. So patients who are willing to have that type of put that much effort into training themselves and getting them ready for a neobladder may be a good candidate. It's a lot of work because part of having a neobladder is that it's a bigger surgery, bigger recovery time. Not only that, but patients who have a neobladder may potentially need to learn how to catheterize themselves for several months because sometimes the neobladder is not ready to be able to empty itself, and you have to learn how to catheterize yourself during that time until the body or the patient's accustomed to being able to empty the bladder by a Valsalva maneuver or a Purday maneuver. That's a neobladder. The other thing is that the neobladder may be planned, but sometimes it cannot be performed at the time of surgery because of one, anatomical findings showing it's very difficult to remove a longer piece of intestines and to form a neobladder, or that there's more extensive cancer at the time of the surgery that makes it difficult for us to proceed with a neobladder. And then finally, patients have to qualify for neobladder. Patients who have intestinal problems, inflammatory bowel disease, prior radiation to the abdomen or pelvis may not be a good candidate. And also patients who have compromised renal function, those patients would also not be a good candidate for a neobladder. And then, of course, patients who need more treatment for their cancer after surgery are not good candidate for a neobladder. As for the ileal conduit and the catheterizable pouch, of course, those two require long-term care for, again, also long-term care for their urinary, long-term urinary care, meaning if you have a ileal conduit, you need to be ready and able to change out the appliance or the bag. That usually has to be managed, of course, every day to be able to empty the bag, but to change out the bag, that has to be done about once a week. In catheterizing a pouch, of course, the patient has to be willing and able to catheterize the pouch, to empty the pouch. And the danger of not emptying a neobladder or the pouch is that if it gets too dilated or distended, there could be compromise to the pouch. It could burst. You could cause retention that can increase the pressure within the neobladder or the pouch and causes translation of that pressure up into the kidneys and quote unquote blow out the kidney and cause renal insufficiency or renal failure. In addition, if you're not able to empty the neobladder or the pouch well, you can form infections as well as stones and also again urinary retention. So it's important that before choosing a type of urinary diversion, you have to be ready to understand the possible responsibilities and care that you need for each of these urinary diversion, as well as the risks and benefits and the benefits and the drawbacks of each of these forms of urinary diversion. So one of the things that we need to consider also in a cystectomy is that the patient may want a urinary diversion, but if they are undergoing neoadjuvant therapy, whether it's neoadjuvant chemotherapy or neoadjuvant immunotherapy, after they've had those type of therapy, it may change their ability to have any of those type of urine diversion. For example, if a patient has neoadjuvant chemotherapy and the chemotherapy compromises their renal function, then what was a good candidate for a neobladder may no longer be a good candidate for a neobladder because of the compromised renal function. In addition, if you are having neoadjuvant therapy with immunotherapy or chemotherapy, during the treatment and after the treatment, if you're still having some side effects or compromised performance status or health, you may not be a good candidate for a pouch or a neobladder and may have to fall back onto an ileal conduit. Now, there's nothing wrong with an ileal conduit. It's a very good option for treatment for urinary diversion. A lot of patients prefer this because of the ease of care, the durability of the conduit, and the ease of care of family and care that can be provided for by family or nurses or healthcare providers. For example, for older patients who are not able to take care of themselves, ileal conduits is a very good option as it can be readily taken care of by an aide or a healthcare worker. So a little bit about the surgery. The surgery, like I said, takes anywhere from 3 to 6 hours, depending on the type of urinary diversion, the type of surgery to be performed, meaning are we doing a cystoprostatectomy for men or are we doing an anterior pelvic exoneration? Typically, a patient should expect to be in the hospital for anywhere from 5 to 10 days. During that time, the patient will be on will convalesce and will recover from the surgery. My patients typically do not require an NG tube or a tube that goes from their nose down to their stomach to drain their abdomen. Most of my patients will regain their bowel function within 3 to 5 days, meaning you would not be able to eat anything substantial until there's evidence of return of your bowel function or GI function. Meaning after a big surgery like this and after manipulating the intestines or the intestine and colon will go into what we call post-operative ileus, where it goes to quote-unquote sleep. It may take a few days before the function will return, meaning we'll monitor to make sure that there's a passage of gas or flatus where you fart, and then we monitor and make sure that you start having bowel movement. Once you pass gas and have bowel movement, that means the intestines have recovered, and that's when you advance on your diet. You go from a liquid diet to a full diet to eating regular food. Once you're eating regular food, that's when we know that you're ready to go home. After the surgery, some patients will have some pain. The pain could be for a few days or sometimes almost for a week because it's the biggest surgery. You'll be provided with pain medication, either IV or pills while you're in the hospital. Also, during the hospital stay, if you have a neobladder, you'll have multiple catheters in your bladder to drain it, as well as drains to help drain extra fluid within the abdomen. And during that time, while you're in the hospital, there'll be instructions on how to take care of a neobladder, how to flush a neobladder. As for a conduit, if you are to have a conduit, then during your hospitalization, the stoma nurse will help with teaching how to take care of the stoma or the conduit, how to change out the bag or the appliance. In addition, we would usually like for you to have someone at home, either a family member or someone who can help take care of you to teach them how to take care of your ileal conduit, so that way, if for some reason you're not able to take care of your appliance and your bag, the conduit, someone is able to take care of you for that. Again, hospitalizations anywhere from 5 to 10 to 14 days. Typically, a patient will go home with being able to ambulate or walk, eat and drink, and have normal bowel movement. Sometimes you go home with a drain, what we call a JP drain, or a drain to remove excess fluid that's in the abdomen from the surgery. Um, and typically that can stay in for anywhere from a week to 2 weeks. Let's see. The follow-up is usually a few weeks after your discharge home, and that's I think that's it for a cystectomy. What else do I need to talk about cystectomy? Let's see. Um, oh, on a pelvic exoneration in a female, when we remove the bladder and the anterior portion of the vagina, there may be compromise in sexual function. If there is a need for preservation of the vagina, that has to be discussed and determined on a case-by-case basis, meaning there are certain cancers that we can try to preserve the vagina. However, if there's a high-grade disease or a lot of muscle invasion into the bladder and certain parts of the bladder, a vaginal sparing procedure is not possible. We typically do not, in the urology world and the oncological world, do not typically want to preserve the cervix and the uterus. However, on a case-by-case basis, this can be performed. It's a very rare and infrequent that the vagina, the cervix, or the uterus is preserved. Sexual function after cystectomy for males. Nerve preservation for the neurovascular bundle for erectile function can be performed with a cystectomy or a cystoprostatectomy. Again, because it's a bladder cancer, not a prostate cancer, that can be performed but however, if there is extensive disease of the bladder, a nerve preservation may not be possible. Finally, let's talk about continence. Continence with a neobladder. If a patient is to have a neobladder, there are some concern about continence. One, sometimes the neobladder may become very difficult to empty, so a patient may develop urinary retention. And if the patient has urinary retention or during the early post-operative phases of a neobladder, there may be some training to help expand the neobladder, but there's also some training to empty the neobladder. If the neobladder is not able to be emptied completely, then intermittent self-catheterization, meaning you have to catheterize yourself to empty the bladder, may be necessary. Now, the opposite is that some patients with a neobladder can develop urinary incontinence, and the urinary incontinence may take time to improve, and this improvement is based upon, one, time, and two, recovery of what we call the external pelvic sphincter or the pelvic floor muscles. So to help improve urinary continence after a neobladder, patient may need to perform Kegel exercises or pelvic floor therapy to help improve their ability to control urine and not develop what we call urinary incontinence. Sometimes this incontinence is in the form of what we call stress incontinence, when there's a cough, a sneeze, or certain movement or lifting that can cause the urine to leak through the neobladder. The other common problem with the neobladder is that there can be what we call nocturnal enuresis. Nocturnal enuresis is when there is urinary incontinence while you're sleeping. So often patients with a neobladder will wake up in the middle of the night not knowing that they needed to urinate and already find themselves wet. That can happen typically early on after surgery, and some patients are able to train themselves and are able to minimize or resolve altogether this nocturnal enuresis, where they're able to either catch it before they wet themselves at night and able to go to the restroom, or some people will have to do what's called time voiding, where they have to wake up, time themselves like every 3 to 4 hours, to get up, empty the bladder so that it doesn't get so full that the body automatically tries to empty it, or the neobladder will try to empty it. So nocturnal enuresis can happen in about 50% of patients, and some of them have persistent, meaning they'll always have nocturnal enuresis, and they would then have to either do pelvic floor exercises or learn how to control it, or do some time voiding or something. But nocturnal enuresis is something that can be quite a problem for both men and women after formation of a neobladder.